Today I'd like to talk about the session, the functional dyspepsia, clinical presentation, and diagnosis. This is my profile now. I'm working in Kyoto University, and now it's a member of the guideline member, Japanese guideline member of functional dyspepsia. First, I talk about the background of functional dyspepsia. The functional dyspepsia is a very common disease. The prevalence of population is about 11 to 70% in the health check population, and among the hospital visitors, about the half the patient is the functional dyspepsia itself. And about the gender difference, the functional dyspepsia is more higher in the women compared to men. The functional dyspepsia impact quality of life is very important. The symptom severity correlate with the QOL reduction. And compare the QOL of the functional dyspepsia is nearly equal to the gastric ulcer or the other chronic diseases, for example, the asthma. About social impact, the functional dyspepsia reduces the daily life and the work productivity. And functional dyspepsia increases the healthcare cost due to the frequent the hospital visits and medical care visits. And the functional dyspepsia often coexists with the GERD and IBS. The FD and IBS overlap is up to the 46%. And the functional dyspepsia is strongly associated with the psychiatric disorders, especially in the anxiety. Now, according to the Roma 4, the criteria, the functional dyspepsia is defined as the border sound symptom as following. The border sound is very important. The postprandial fullness, the early satiation, and epigastric pain and epigastric burning. It needs no evidence of structural disease that could explain their symptoms. And it lasts 3 months with the onset of at least 6 months in advance. It means it's a chronic condition. The subtype of FD is divided to PDS and EPS. The PDS means the postprandial distress syndrome. It's including the postprandial fullness and early satiation. The EPS is epigastric pain syndrome, including the epigastric burning and epigastric pain. The 80% of functional dyspepsia is a PDS, and the PDS and EPS often overlap. This slide is about the typical symptoms. The diet is very important for the FD symptoms. The high fat, the high calorie meals is repeatedly reported to worsen the postprandial fullness and early satiety. And the fat intake is particularly associated with the delayed gastric emptying. The coffee, alcohol, and the soda drinks is commonly reported to patients as symptom triggers, but the interventional studies showed inconsistent results. The wheat and gluten, some association is suggested the gluten-free diet may improve symptoms in the selected patients, but effects are limited in the non-celiac disease cases. And the meal size and timing, the smaller and the more frequent meals may alleviate the symptoms compared with large meals. Next, we go to the case presentation. The 60-year-old woman, this is a real case of my patient, Chuyên. And the chief complaint is the postprandial fullness. The patient had experienced the gastric heaviness for several months. Also, the prescribed prokinetics and the other medication by the primary care physician, the symptoms did not improve, and the patient was referred to our gastroenterology department. She had no history of surgery, and she is under treatment for the diabetes by the primary care physician, and she had no allergy. What should you ask next in the history? The item to ask in history is a lot. The first, the symptom details, the onset and the cause, the since when, the persistence or intermittent, and location and nature. Epigastric painfulness and early satiety is the subtype of functional dyspepsia. The severity and the impact of daily life is important for the patient, the cure. And the diet and lifestyle, the factor that triggers, as the said as before, the high fat meal, the soda drink, the alcohol and coffee will sometimes affect the symptoms. And the relieving factor is sometimes small frequent meals and rest. The stress and psychological factor, the symptom worsening. Around future is important things. The weight loss, the melena, dysphagia, the persistent vomiting, the family history of gastric cancer. This indicates the gastric cancer or gastric ulcer in the structural diseases. When we see the around future, we have to consider about the endoscopy and the CT scan and the advanced the test. And about the past and the condition, the diabetes and the thyroid disease, the peptic ulcer, the GERD, the hepatobiliary, the pancreatic diseases, and the surgical history. These conditions affect the gastrointestinal symptom and motility. And the most important thing is the medication history. NSAID, the antiplatelet, the bisphosphonate, the anti-diabetic drugs, especially in the GLP-1 analog, metformin, DPP-4 inhibitors, the alpha-GI. And for hypertension, the calcium blockers, the nitrates, and the opioid, and the anticoagulants, and the antidepressants, and antibiotics. These medication can influence the gastrointestinal symptoms and motility. And the psychosocial background, the anxiety and depression and sleep disturbance, these kind of the background affect the gastrointestinal symptoms. Back to the case presentation, this patient on the further the history taking, it was revealed that the patient had started the GLP-1 analog therapy for the diabetes a few months earlier. After discontinuation of GLP-1 analog, the symptoms improved and the prokinetics were no longer required. This case represented the dyspeptic symptom caused by impaired the gastrointestinal motility induced by GLP-1 analog. And this is the simple diagnostic flowchart for the functional dyspepsia. When you see the dyspepsia, the first thing you have to thinking about is to exclude the drug-induced symptom and the other, the community situation. And after that, you can just start to the empirical treatment, for example, PPI or prokinetics. After that, you can, if you see the around future, the other possibility diseases, or the no H. pylori test, no initial endoscopy, so you can thinking about to proceed to the endoscopy or the other tests, including the CT scan or the other test, to exclude the structural diseases. After that, you define the patient as a functional dyspepsia, go to the treatment. The special treatment will be described in the next session. I don't explain the details in the session, but the treatment is divided. Maybe it's the different in the regions. Maybe you can follow the regional guidelines. The globally, the PPI and the prokinetics is the first we prescribed as the first, but in Japan, the first line is the PPI and the herbal medicine, and acotyamide is a polyesterase inhibitor. Finally, I explain about the H. pylori associated dyspepsia. It's called HPD. The Helicobacter infection is also known causes of dyspepsia symptoms. This meta-analysis shows that the H. pylori education is significantly improved the dyspepsia symptoms. The odds ratio is 1.54 in Asia. The benefit is the greater in Asia compared with the other regions. The supporting more aggressive eradication therapy, the H. pylori education is not only to improve the dyspepsia symptom, but also to prevent the gastric cancer. The proactive test and treat strategy is recommended. In conclusion, the functional dyspepsia impairs the quality of life and the symptom relief improves the patient satisfaction. Exclusion of underlying causes, especially drug-induced dyspepsia, is essential before the diagnosis. Thank you for your attention.